Welcome to this first SOLACI Peripheral webinar. I'm Anibal and I have the pleasure to co-moderate this session with Dr. Mauricio Cavalieri. Mauricio, can you hear me? And would you like to get started with the webinar?
Okay, I can hear you well. Maybe you can present the other guys that we are here with us. What do you think?
Okay, Mauricio. We have the pleasure today to have as an international guest, Dr. Alberto Cremonesi, very well known for all of you. Dr. Cremonesi, thank you very much for being with us this evening at this SOLACI webinar. And we have also Dr. Estêvão Martins and Luis Virgen as case presenters, and we have panelists, which are Dr. Daniel Sanutini from Argentina, Dr. Felix Damas from Mexico, and Dr. Marcos Marino from Brazil. We hope that all of you will really take advantage of this first SOLACI Peripheral webinar. I think that carotid interventions are very challenging, and we want all of you to participate actively through the chat in this webinar. So Mauricio, if you want to go ahead.
Thanks a lot, Dr. Damonte. Hello, everyone. Before we go to our hot topic tonight, I want to take 5 minutes of your time because today is also the official launching of SOLACI Peripheral, and this is the new department of SOLACI, and we are very happy to be here with you. And I will spend the next 5 minutes, it is quickly, just to show you how important it is for us, and we hope for you too. Next slide. As you can see, do you recognize this guy over there? Well, to talk about SOLACI Peripheral, I'm going back 4 years when I went to Milan to attend this meeting, and I took this picture of Dr. Alberto Cremonesi because I found the lecture of him particularly inspiring. And next slide. As you can see, I took a picture of myself too. And I don't know if you can see, but I took this picture because I wanted to memorize the sentence just beside me, that it was made for interventional cardiologists committed to treating peripheral artery disease. And it made total sense to me at that time. And next. Because in 2016, we had already begun our experience in Brazil, coordinating an endovascular course that soon became the official endovascular course of the Brazilian Society of Interventional Cardiologists, and with the help of Dr. Marino and Dr. Estêvão here with us today. And the model is we stay 8 months together with a small group of 15 to 20 people, and we meet every month. And the small group can have lectures, can have virtual simulation, as you can see there on the top right, and can more than this, can go inside the cath lab with the proctors and do the cases together. And after 8 months, you can see on the top left, our former president of Brazilian Society, Dr. Viviana Lenk, handling a certificate for a dear friend, Dr. Renato Borges. Next. So, because of this good work, I believe, I was invited by Dr. Mangione, our SOLACI president, to try to replicate some of our results in SOLACI. And first of all, I asked SOLACI to do an encuesta, a small survey, about what the colleagues were doing in Latin America for peripheral interventions. And there are a lot of cardiologists doing peripheral interventions in Latin America. And the essential results are here next. As we are talking about carotids today, those that are already performing the endovascular procedures, 50% say yes, we do carotids, and 50% say no, we don't do carotids. But what is good is the overwhelming response we had when we asked if they wanted to see more training or more information about this kind of procedure. And next. The response was a sound yes, that would be great. Next. So we start in 2020 with 8 friends at first that we are working together in SOLACI Peripheral, and we are trying to reach the goals by different fronts. As you see, taking care of the registers, you will find Ana Malone from Argentina and Luis Vigin from Mexico. Daniel Zanuccini here from Argentina is uploading clinical cases in the SOLACI site, and it's open for everybody to discuss. Helping us with research, we have Dr. Gustavo Pedernera, and we have other friends, Dr. Alex Goldsmith, Estêvão Martins, Felix Damas, and Maxi Rossi. Everybody is doing a little bit to make the engine work. Next. So that's why you're here to our first webinar. That's why the topic is carotid interventions, and that's why it makes total sense to have Dr. Alberto Cremonesi here, because he somehow inspired us for it. Next. We are happy to say, and I would like to say thanks that we have the support of all these societies from Argentina, Brazil, and Mexico, and also from our sponsor Cordis, that I really appreciate the support. Next. I'm coming to the end. Well, SOLACI, as you know, represents 20 countries, and we are in a regional population of 570 million people. And if you imagine SOLACI as the home, as the house of interventional cardiologists here in Latin America, I want you to know now that we do have a small comfy room inside this house. And I want you to think that this is the new department, SOLACI Peripheral, a comfortable room where we can join together, we can discuss our cases, we can improve together our skills in peripheral interventions, and we want you to join us as soon as you can. And this is my last slide. Next. So that's what I had to say, and bienvenidos. Did you like the bienvenidos, Dr. Damont? I've been trying to do it right.
Excellent, Mauricio. So would you like to introduce the lecture of Dr. Cremonesi?
Okay. I don't know if I need to introduce Dr. Cremonesi, but he's maybe one of the most important guys in the world concerning to carotid interventions. He's chief of cardiology from Humanitas, now in Italy, in Bergamo. And it's a pleasure to have you here, Dr. Cremonesi.
My thanks to all of you. I have to tell you, you said that is an honor for you, but mostly is an honor for me to stay with you and to try to share my experience, which is a nearly experience. We started around 97, our first carotid intervention, endovascular intervention. But for the sake of time, I really wanted to go immediately and to share with you some concepts, some personal reflection about what is today carotid artery stenting. I have to say that sometimes when I ask myself what is carotid artery stenting, I am raising a dilemma or probably an hypothesis. Because when we give a patient a carotid artery stenting procedure, do we give a similar outcome than carotid endarterectomy in a less invasive way? This is the most important point. For this reason, I wanted to address a very simple agenda about state of art of carotid artery stenting in terms of are we complying with the current indication and guidelines? Do we still today have unmet need and limitation? Is technology advancement impacting positively on the outcome? And some reflection on future direction. First point, comply with indication and guidelines. I really don't want to kill you with many scientific data, but just to remember all of us a piece of history, because until 2010, you see how many data we produced, we in terms of community, we produced for demonstrating what is really carotid artery stenting for our patient. We had randomized trial, we had a lot of single center experience, but the real point was that in any case, the trend was really positive, because if I start in 1992 with a 10% complication rate from Cavata's randomized trial, we dropped down in 2010 around 2.5–3% overall complication rate. Nevertheless, in that time, the same year, a meta-analysis, pre-planned meta-analysis of individual patient data from 3 important trials, EVA3S, SPACE, and ICS, demonstrated a great superiority of endarterectomy over carotid artery stenting. In any kind of endpoint, stroke, death, disabling stroke, all cause on death. So it was quite disappointing at that time, but fortunately, the same year, we had the data from CREST for carotid revascularization endarterectomy versus stenting trial, a very well done trial in terms of design, stent and embolic protection consistency and hypothesis. But the real point was that for the first time, we demonstrated in terms of a primary endpoint no inferiority for carotid artery stenting versus carotid endarterectomy, with more minor stroke for carotid artery stenting, more myocardial infarction after carotid endarterectomy, but in terms of major stroke, no difference at all. Not by chance, the same year, some years after, 2016 more or less, the same investigator, the CREST investigator, demonstrated the long-term outcome of carotid artery stenting. And you see here that no difference in primary composite endpoint, in terms of stroke and death, in terms of any stroke, without any interference with subgroup analysis age, sex, status, symptoms, or severe or moderate stenosis. 1 year after, European Society for Vascular Surgery and European Society of Cardiology was a joint guidelines, brought us very important data on the way to treat symptomatic and asymptomatic carotid stenosis. At what was very clear, some points. It is obvious that carotid endarterectomy for asymptomatic and symptomatic is still today considered a primary option, but carotid artery stenting plus best medical therapy can be considered a good alternative for asymptomatic and symptomatic. But what came out from these guidelines was operator and center experience play the major role in individual treatment strategy. So it is obvious that we have other accepted indication for carotid artery stenting. You remember the time-honored restenosis or hostile neck or pseudoaneurysm, arterial dissection, fibromuscular dysplasia. But in any case, if I have to give an answer, a very honest answer, are we complying today, 2020, with the current guidelines? I have to say yes. And now I wanted to address the second point about carotid artery stenting, because carotid artery stenting is not always a blue sky where everything is going in a very simple way. It's still today a very complex procedure. And when we go and we try to understand exactly technical and clinical issue, in order to simplify our vision, I have to say that we have device-related, anatomy-related, and access issues. Mostly device and anatomy, stent conformability and scaffolding, coverage and containment of unstable plaque, hostile aortic arch and supravessel aortic trunks, and in some cases, not many, but having the possibility to perform the carotid procedure in alternative accesses can be very important. The most important point probably in the stent era is the brain protection. We know that if I address a very soft plaque, embologenic plaque, I can have intrastrat plaque prolapse and post-procedural embolic events, means late strokes. We invented a lot of ways to protect the brain during the procedure, but once finished the procedure, and I continue to say that we have to protect all our procedure with protection devices, because the embolic load you may generate during the procedure is absolutely unpredictable. But what is going on after the procedure? Unfortunately, we know that the carotid plaques sometimes are very embologenic, because we are treating vulnerable plaques, ulcerated plaques, hemorrhagic plaques, and for this reason, stroke prevention by plaque coverage with a dedicated stent is indicated. And now we can address the point of technology advancement, because today when we speak about protected carotid artery stenting, we can rely on innovative solutions for overcoming carotid stenting limitation. And I am speaking about micromesh era and alternative accesses. Sometimes I bring to the attention of all of us this historical slide. You see that you have in this complex lesion a beautiful angiographic result, but when we go inside the vessel and in the stent and we study with intravascular ultrasound the final result, you see a huge plaque protrusion. Also, we demonstrated in very symptomatic patient, for example, as in this patient, that OCT, optical coherence tomography in carotid artery stenting, can show that sometimes you do not cover completely the plaque and you have an important plaque prolapse. For many reasons, we are asking us how to choose a correct stent, and we pointed out that many factors are impacting this answer. But the most important point today is really to focus our attention on stent technical feature and scaffolding and conformability. Today we have two micromesh, at least in Italy, I don't know in your country, but we have two micromesh double layer carotid stents. What does mean double layer? Means that there is an important layer which is going on to exert a radial force to keep the artery open, but also there is a second thin layer for plaque containment, as in this case where you see the Rod-Saver Terumo carotid stent. We checked in this patient treated with proximal protection and Rod-Saver, very good angiographic result, but what was very important was the reconstruction inside the vessel of the result from OCT, and you see clearly that the thinner strut is going to contain any kind of plaque protrusion, big or small. We have not many scientific data on the use of dual layered stent. This is a recent meta-analysis on 4 clinical studies. What we know today is that if we use in our patient this kind of stent, we have a low rate of peri-procedural adverse event and near elimination of post-procedural adverse event. But please, I don't want to push you to think that we can use in all the patients. For sure, I think that we are at the beginning of a new paradigm in carotid artery stenting, but remember that we do not have randomized clinical trial data, and for this reason, I don't think that we have robust evidence about the implementation of this new type of stent to every CAS procedure. I also want to strongly back the use in a specific case of radial or brachial approach. Obviously, I'm a cardiologist and I love radial approach. Why? Because we are not touching the aortic arch, which is sometimes a very embologenic source of emboli. We have data, important data in this systematic review and meta-analysis about the procedural success via radial approach for carotid artery stenting. Great result. Is not an easy task, but anyhow, if we consider that also from radial we can use with particular technical advancement also the proximal protection, I have to say that is a great option for a lot of patients. If we are not able to perform radial or brachial, today we have the transcervical carotid artery stenting, which is mostly dedicated to surgeon, 1-2 centimeter neck incision, local anesthesia, and the flow reversal circuit from carotid artery to femoral vein to remove the embolic debris. Which kind of future direction? Very simply, we have many ongoing trials and we wait really for the data, mostly from SPACE 2, CREST 2, and the X2. But why? For the simple reason that some years ago, in 2016, David Spence and Ross Naylor raised an important point. The problem is clear. How best can we treat the asymptomatic patient, endarterectomy, stenting, or neither? Today, we know that we can identify asymptomatic patients who can benefit from endarterectomy and stenting. It is not an easy task. We have to rely on transcranial Doppler, very well done DUS, but also if we have this technology, the PET-CT can help us to recognize not very high-grade stenosis, but the unstable plaques. Last point is the acute ischemic stroke, and I want to mention carotid artery stenting and acute ischemic stroke endovascularly treated for the simple reason that for us interventionists, the carotid stenting is the first step to address everything is in the brain. I am at the end of my talk. It is obvious that my personal feeling is that protected carotid stenting is absolutely a mature alternative to carotid endarterectomy for ischemic stroke prevention. It is obvious that we have to reserve carotid stenting to symptomatic severe stenosis or asymptomatic patients who are shown to be at higher risk for stroke with medical therapy than with intervention. Latest technical advancement as a micromesh stent, double layer technology can help, and a lot, mostly in unstable plaques, and also advanced vascular and intravascular imaging can help us to take the right decision for individual treatment strategy. Can be a primary choice treatment for sure, yes, but please don't think that carotid artery stenting can be used for all the plaque. Can be in very expensive center, but it is always very complex. What I want to stress is that all plaques for all interventionists is a concept absolutely not applicable. And I continue to say after more than 20 years experience that competence makes the difference. I really thank you for the patience you had. Thank you very much.
Thank you very much, Dr. Cremonesi, for your outstanding presentation about this state-of-the-art in carotid artery stenting. And if Mauricio agrees, I would like to invite our panelists to ask you questions. We have 10 minutes for questions. Dr. Marcos Marino, Dr. Felix Damas, or Dr. Daniel Sanuccini, would you like to start with the questions to Dr. Alberto Cremonesi? Marcos? You are
can
mute,
hear
Marcos.
Dr. Marco Mauricio. He needs to start with the microphone.
Okay,
I'd like to talk with Alberto Cremonesi about what's the indication for the mesh stents. All patients, specific patients, unstable plaques, because it's not a reality now in Brazil about maybe to see what you know, what say we don't know, just arriving. But the mesh stent is a solution for all the problems.
No, absolutely no. I continue to say that we have to really tailor our procedure about the specific need of the patient. Many times, for example, in very calcified plaque, I do not use this double layer mesh stent. I use still today standard stents, which are absolutely perfect with very high radial force in that and very good conformability. My concept, my general principle for the use of double layer mesh stent is, firstly, the symptoms. If a patient is a true symptomatic patient for neurological symptoms, I prefer to go with proximal protection and the double layer mesh stent for sure, because the plaque coverage is much more predictable. First point. The second point is also the anatomy. Sometimes when we use this kind of stent, important tortuosity or angulation are not allowed with this kind of technology. You can modify so much the original anatomy that still today I prefer standard stents.
Okay, thank you. Dr. Felix, please.
Thank you. First of all, thank you, Dr. Cremonesi, for this outstanding presentation. It's a really pleasure, especially for Estêvão and me here and share this webinar with you. And I would like to ask you if, how do you see the future of the approaches? I mean, which percentage of radial approach or femoral approach do you use, and in which patient do you select which one?
Yeah, many times today the patient are previously checked with an angio-CT. And you can recognize the aortic arch and the atheroma in the aortic arch. When we see a very atheromatous aortic arch, we prefer the radial approach. The radial approach is not always very simple, I have to say. Mostly if we wanted to treat, for the right one, the right carotid is quite a simple process, but if you wanted to treat the left carotid, sometimes is tricky, but in any case, you can do whatever you want. The real point is that radial should be checked before. The dimension of the radial should be at least 2.73 millimeter in diameter, otherwise you can have a significant spasm. But still today, I have to say that 75% of our procedures are done by femoral approach, not by a radial approach. For us, in terms of cardiologists, we are very skilled in catheter-based intervention, so it's not that complex to access the supraortic trunk, and in a very gentle way, without wiping too much supraortic, in the aortic arch. So 75-25.
Okay, Dr. Daniel Zanutini, I think you have a question for Dr. Cremonesi.
Okay, thank you. Congratulations, Dr. Cremonesi. Thank you for your presentation. And recommendation for management of asymptomatic carotid artery disease in the trial, comparing endarterectomy with carotid stenting. In average risk for endarterectomy asymptomatic patient, the two biggest, the CREST and ECT1, requires exclusively experience intervention. In ACT1, the 2.9% rate of death stroke after carotid stenting fell within the 3% accepted risk. Because of the learning curve associated with carotid stenting, has begun performance is small number by multiple specialists. It's possible to whether the death rate, death and stroke rate reported for carotid stenting in this trial can be replaced in the real world practice?
Yeah, you touched a critical point, which is the real experience of the operators and the center. My position is really clear. If you want to start a program for carotid artery stenting, you have at least to plan that 50 procedures per year, at least, should be done in the center. And if you start with such a number, what I recommend, not divide these 50 procedures with too many interventionalists. Generally speaking, I think that you have to get experience. 50 procedure means one procedure per week is not a very huge number of experience. And back to the point of asymptomatic. Yes, apart of that, I continue to say that the asymptomatic should be treated with carotid artery stenting or endarterectomy only if we have a lesion more than 80%, so a tight lesion. And then, as I said, today we are looking to these asymptomatic patients to try to understand if they are at high risk for stroke. It's not simple. Sometimes it's time consuming. But once again, if I think that I am in front of the asymptomatic patient and with my procedure I can provoke a stroke in that patient in terms of peri-procedural or post-procedural stroke, I need really strong evidence that in that specific patient we have to do something more than a best medical therapy. And then obviously, great operator always, and so you go to the real world, and my position in real world is a decision, an important decision for a center. If you want to start carotid, please at least you have to perform at least 50 procedures per year. Otherwise, it is really better to send the patient to a vascular surgeon, a very good vascular surgeon, I tell you.
Okay, great. I think we should move on because we have two very interesting case presentations that will take place right now. We had the first presentation by Dr. Luis Virgen that I think Dr. Luis Virgen had some problem at the cath lab, some emergency, and Dr. Felix Damas is going to take his place and present the first case. Dr. Felix Damas.
Hi everyone, Luis Virgen has a family emergency that is impossible to avoid for an interventional cardiologist. And now as we said, I am the emergency hitter for this presentation. I would like on behalf of Luis Virgen, I'm going to present his cases. Now, there is a 82 years old male patient. He presented with stroke 2 weeks ago with right hemiparesis. He had history of hypertension and hypercholesterolemia. And at this point, he started treatment with aspirin, clopidogrel, and atorvastatin. We heard about the atorvastatin and also the rosuvastatin has a good influence in the prognosis in patients with carotid atherosclerosis. Let me advance. Okay. A CT angio was performed for this patient, and they found left internal carotid artery occlusion that maybe is responsible of the symptom of this patient 2 weeks ago, and a critical right stenosis with a calcified plaque in the right internal carotid artery. You can see the image here. They have very spots of calcium in the tract. Now, this patient was discussed with the surgical team, and they considered this patient of high risk for carotid endarterectomy. So, at this moment, we know that the contralateral occlusion of the carotid artery, it can be feasible to do with carotid artery stenting without representing a very high risk procedure. But it's not only about only the carotid occlusion, contralateral lesions, like features of high risk. There are another features of high risk that can be considered, like age, like cerebral flow reserve, or heavy concentric calcification of the lesions need to be considered. But also, as Dr. Cremonesi said a few minutes ago in his presentation, the experience of the center, of the experience of the interventionalist is very important to take decisions or to offer to the patient which procedure can be better for him. Now, in this presentation, originally, I would like to answer the first question. I would like to comment that we have no doubt about what is the best for this patient. And for this patient, the optical medical treatment is not the best choice. It's a patient of high risk of stroke and disability of stroke. And we need to discuss about what is better for him, carotid endarterectomy or carotid arterial stenting. I think this depends for many centers, depends of the confidence of the surgical team and the confidence of the interventionalist. And as in my center and also in the center of Luis, maybe the carotid arterial stenting can be offered to this patient with a very good result. And at this point, I would like to ask to Dr. Damonte if he can continue the discussion with these other two questions.
Yes, Felix, thank you for the presentation of the third part. And I would like to ask the panelists about these three questions. First, I would like to start with Dr. Mauricio. And I would like you to comment about what would be the best treatment according to the evidence and according to your experience for this patient.
Well, it is in the guidelines of European guidelines and North American guidelines as well. And I think this case fits perfectly to our meeting, because it is a symptomatic patient. It is high risk for surgery because it has a contralateral occlusion, and it is within 2 weeks of the ictus, and there's no doubt the patient can be treated invasively, and the best time to treat, according to the guidelines, would be in the first 2 weeks, because we have the risk of it recurrence. Okay. Anyway, the first 48 hours, there is some doubt if the invasive procedure can be done safely according to the guidelines. Not much for the carotid endarterectomy, but especially for CAS. So the best time would be sooner, okay. If you can do at 2 weeks, that's okay.
Okay, thank you, Mauricio. Daniel, would you like to make any comment about what would be the best time to treat this patient?
Sorry, didn't get the question.
Yes, in the recommendation of revascularization in patients with symptomatic carotid disease is preferably within 14 days of symptoms. Is the class 1 and level of evidence A. Okay, is indication.
Okay, and Dr. Marcos, would you like to make any comment about what kind of brain protection unstained would you use in this case?
I think it is for directly, I use a femoral procedure and distal protection. It's very frequently about, I use in my hospital about 95% of the proximal distal procedures. It's I think it's the best. I use sometimes a pre-dilatation or pre-dilatation, as you can discuss about it, and use a standard stent. It's about Dr. Alberto Cremonese said about this. I can use this frequently, or the closed cells or this open cells, but this accommodation by curving. It's more reason for us working in cath lab to intervention cardiologists use the guided catheter and the distal protection for these patients. It's my opinion.
So thank you, Marcos. Before we go to the treatment procedure by Dr. Felix, I would like to take advantage of the presence of Dr. Alberto Cremonese here to ask him a short comment about your strategy in this case, Dr. Cremonese.
No, apart the best time, I fully agree with all the comments raised. Which kind of brain protection? Generally, in a very symptomatic patient, I prefer proximal. But in this case, there is a contralateral occlusion. And then we could say, okay, is a contraindication. Actually, it is not a contraindication. We have to understand exactly the brain perfusion, the contralateral brain perfusion, and you can check with a very short occlusion. But I have generally I go in proximal. If the patient doesn't tolerate, I switch to a distal and with the filter, and I use the MoMA as a delivery catheter, nothing more.
Okay, thank you very much. So Felix, would you like to go ahead with the case?
Thank you. Thank you. Okay. Now, when I talk about the procedure, this procedure started also, of course, with local anesthesia. An 8-French sheet was placed on the common femoral artery, and the common right carotid artery was engaged with a 6-French Simon's curved tube over a 35 hydrophilic wire, and then it was replaced with a stiff wire on the external carotid artery to place a multipurpose catheter on the common carotid artery. we have no doubts about the use of heparin, of course, and in this case, a distal embolic protection filter was the selection of protection device for this patient. He take account the contralateral occlusion, and now he decided to use distal protection filter. Now, the lesion was related with a 275 by 20 balloon. This because of the small spot of scalcium in this lesion, and the self-expandable stent, a tapered self-expandable stent 6.8 by 14 was deployed at the moment of deployment. 1 milligram of atropine was used, and a residual stenosis of 40% was absorbed inside the stent. Because of that, post-dilatation was performed with a balloon 5 by 15 to reach a good angiographic result. This is the final result of this patient. We can see a good angiographic result, and we, of course, with the final cerebral angio, we can see no distal embolization on this, and recovering of the contralateral and the preserved of the contralateral circulation was preserved at the end of the procedure. The patient was discharged without no complications. This is the final slide. I don't know if you have any comment about this case.
Thank you, Felix. Thank you for your presentation and for sharing the case with us. I think that for the sake of time, we should move on to the second case. So I will ask Mauricio to moderate this second case. Mauricio?
Okay, do you hear me?
Clearly.
Yes. Dr. Estêvão Martins is going to present the next case, and the topic now is proximal protection.
So, okay, let me just, can you see the screen, Mauricio?
Yes.
Yes. Okay. So first of all, I'd like to thank the SOLACI organization for inviting me, and also to Dr. Roberto Cremonese for accepting the invitation, because we know that now it's about midnight in Italy and he's still with us. So thank you very much for this kind participation. So the case we are going to approach now is a complex case with proximal cerebral protection. So at the end of this presentation, we will have discussed about the risks of treating a soft carotid plaque, handling acute carotid lesion, and also the clinical use of proximal cerebral protection device. So let's go directly for our patient. Is an 85-year-old lady with hypertension. She was a former smoker, a heavy smoker, I must say. She developed COPD in an advanced stage, the gold 4 stage, and the index symptoms occurred in August 2018, and the patient presented with a transitory modification on her behavior, and also the decrease on the force on the right arm. The patient was admitted within 16 hours of the index event to a private hospital in Rio for screening for acute ischemic stroke. And on the admission, the patient showed a discrete force reduction on the right arm, NIH stroke scale about 1. This is very low in the scale. And what we noticed, it was a very huge thoracic kyphosis. Regarding the EKG, it was sinus rhythmus, and the lab it was okay. So we proceeded with the MR of this patient, and this exam confirmed the hypothesis of acute ischemic stroke, and we could see multiple acute embolic lesions, like embolic shower. You see in the right picture a lot of points of embolic lesions corresponding to the middle cerebral artery, left middle cerebral artery, Here on the middle picture, you see this is the territory of the middle cerebral artery. This one here we cannot confirm it's a middle or posterior, but here in the third picture, it's the occipital lobe, and for sure it's the territory of the posterior cerebral artery. So we have here the left hemisphere committed with that, and with two arteries involved in this case, generating embolus. So we continued the investigation with angio-MR, and in this case, we could see critical obstruction, about 95% in the internal left carotid artery. And you can see here in the detail, that's a high burden and heterogeneous carotid plaque, very embologenic plaque. We can see also, if you look here upstairs, you see the fetal posterior communicating artery pattern. I mean, the posterior cerebral artery arises from the anterior circulation. So it's why a lesion, now we can understand a lesion on the carotid artery can embolize to the middle cerebral artery and also to the posterior cerebral artery up to the occipital lobe. So this was a paper that I had the honor to publish with Dr. Cremonesi, that we proposed a classification for segmenting all the vascular characteristics of the patient in 5 zones. And with that classification in mind, I would like to analyze this angio-MR. And we can see here that this aortic arch is a bovine aortic arch, as the left carotid artery arises from the brachiocephalic trunk in this case. On the proximal vessel zone here, we see that we have 2 bands, about 90 degrees. It's a severe band on the tortuosity on this proximal vessel. Regarding the vascular pattern of the stenting segment, it's not that an issue. It's a mild tortuosity, as you can appreciate here, but we know that the critical aspects is about the lesion itself. It's a very embologenic and heterogenic lesion. So then we administered to the patient aspirin, clopidogrel, atorvastatin, 80 milligram, and as a case summary, we are talking about an 85-year-old female, a symptomatic patient with a minor stroke. The patient has a severe COPD with thoracic kyphosis, severe thoracic kyphosis, and a high-risk plaque with a bovine aortic arch with proximal vessel tortuosity. I think that this patient specifically is a high-risk patient for carotid endarterectomy, carotid artery stenting, and only medical therapy. So I think that, Mauricio, if you want to stop the case here and argue a little bit.
Oh, yes. Thank you very much for the case. I see the operator already started clopidogrel. So yeah, we know that he plans to do CAS, of course, and that's and that's why you're here. But that would be a good case also for carotid endartery, right? Because we have a minor stroke, 24 hours, right? Very old lady, 85 years old. And I don't know if she has some anatomic risk for surgery. Maybe the neck's not so good, I don't know, because of the kyphosis. Is that a case, Estêvão?
Yeah. After this discussion, I'm going to talk about the vascular surgeon. He analyzed the neck of the patient, and the kyphosis was very pronounced. So we definitely saw this neck as a risk factor associated with the severe COPD and also the age.
Okay. Not that I think we could do either, you know, we could do CAS or we can do endarterectomy. If you have experienced hands, you can do both. I don't think one is going to be superior than other, but that's okay. And what we can see here is the bovine aortic arch, and maybe we already know that we are going to do it as soon as we can. It is the best to do because the patient has symptoms. And there are two options now. We can have it from femoral, or maybe because the aortic arch is bovine, that could be a good case for radial approach. What do you guys think? Femoral or radial approach? Generally speaking, general question for everyone.
If I can comment, I tell you that in this case, I mean, it's not an extreme bovine arch, and so for this reason, I would go at least as a first intention from femoral with MoMA, with the proximal protection.
MoMA is 8 French, like, so that's the reason you choose 9. That's the reason you choose the femoral, right?
Yeah, but you could also go from radial, but
maybe brachial, right?
No, from radial, because we have a specific trick to go without an introducer. So we go directly with the MoMA with the 2 wires. Is named NOMA technique, but in any case, in this situation, I would like to use a 9 French MoMA, and for this reason, I would like to go from the femoral axis.
Okay. Any more comments?
I would like to comment something. It's a very tough case because it's a high risk patient for everything, also for endarterectomy and for carotid artery stenting. And also, I would prefer in this case go to transfemoral because there are also bendings on the subclavian approach to arrive to the left internal to the left common carotid artery. And so in this case, I think is the bovine arch with a left common carotid artery compromise. And because of that, I think we can be more confident with a femoral approach in this case, and it's a very tough case.
Okay. Can you go ahead with the case, Estêvão?
Yeah. So thank you all for the comments. So of course that we discussed this case a lot with the geriatrician, the neurologist, the vascular surgeon, and we as interventional cardiologists. And we decided to give a chance for the endovascular procedure. So we decided to do a carotid angiogram with intention to treat with the proximal protection device, as Dr. Alberto Cremonesi said. So standard approach, local anesthesia, 6 French arterial sheath from the right femoral artery, heparin, Judix right catheter, and hydrophilic wire. So we did the first catheterization, the first angio of this lesion. So as you can appreciate here, we see the volume of the plaque, even here in the tail. Let's just move here, okay. Here in the tail, and also we can appreciate that there is a fracture here on the plaque. On this point here, you see that the contrast entering into the plaque, and also a plaque rupture or even filling defect, pointing to a small thrombus here. So it's a very emboliogenic plaque, this one, very emboliogenic. So the first mission that we have when think to implant, to position a proximal protection device is to place a stiff wire in the external carotid artery. I'm not talking this because I invented this. I learned all this with Dr. Cremonesi. So if you are able to put here a stiff wire on the external carotid artery, even to occipital artery, of course that it can be difficult to advance in this case, but with some soft maneuvers, you can advance the MoMA device until the beginning, the first segment of the external carotid artery. So that is our first goal in this case. if you will reach this case, this scenario, okay, we would proceed with the carotid artery stenting. So this is lateral view of the cerebral vessel, just confirming here the fetal pattern here of the posterior cerebral artery, and explain why it could embolize to the occipital lobe. And then this is what we did as a strategy. The flows come from anterior from the carotid, posterior from the vertebral. What we intend to do is to block here on the external and then the common carotid artery, and then to block this flow. But even though we have to think that this particular patient, she doesn't have the complete polygon of the Willis perviety, because there is no communication of the posterior cerebral artery with the basilar artery, the left one, you know. So the only thing that we can be confident is about the anterior communicating artery. So it's a tough case only for proximal protection devices. So as it's a very, very, very high embologenic case, I took the profit to use the seatbelt, airbag and seatbelt technique. I mean, to use a filter device through the MoMA device. So two protections in this case, for neurologic intolerance and also for the embologenic risk of the plaque. So here the MoMA is in place. You see the distal balloon on the external carotid artery, the proximal balloon occluding the common carotid artery. We inject through the working channel here and can do a normal roadmap here, just showing all the lesion, and here the filling defect. So the next step was to advance the filter. As you can see here, it's an eccentric filter that I position here in the distal part of the artery, the most, I may say, normal part of the artery. And then we did a pre-dilatation under proximal protection, under distal protection, with a 3.0 by 20 coronary balloon. And we decided for a double layer carotid stent in this case, because all of what Dr. Alberto Cremonese has said, this is the coverage of this stent will work very well in this plaque. So after that, I did a very gentle balloon post-dilatation. It's one of the best things that I learned with Dr. Cremonese is that we should not stress the lesion. So we go up at least, at maximum 6 in very few cases, but normally a 5.5 in diameter balloon with 6 atmosphere in this case. And we achieved this result. This after aspirating all this column of blood, and after relieving and reestablishing integrated flow, we came across with this result here as the first result. So Mauricio, I think that we can ask about the opinion of the guys here about this result.
Yeah, I can see something different there. But before we go, I want to remember the attendees that they can submit their questions, doubts, and queries in the Q&A section in the Zoom panel, and we'll try to answer them at the end of the webinar, okay? And it's very nice to see that we have 500 people together with us tonight watching this webinar. 500 people.
Great.
Great. What I see there, I can see two things, interesting things for us to discuss. It looks to me, I'm looking at the screen, that we have some kind of plaque protrusion through the stents. You said it was a mesh stent, but even so, I can see some plaque protrusion because the stent is open, and we see a little layer of a filling defect over there. And also a few, yeah, exactly. And also a few centimeters above, there's a accordion effect, I guess. It was not that tortuosity, so maybe it's because of the filter and you know, the stretching of the vessel. But what is most important for us now, it's the plaque protrusion, right? Do you see the images? What do you think we should do now? Stop. That's okay. That's a good result. Use some balloon again, post-dilatation, gently.
No.
Or maybe some pharmacological approach. This is a plaque protrusion, I guess. It's not thrombus alone. What do you think, guys?
Well, one question for Dr. Cremonese is
Yeah.
this is then the comparative, this is stent with carotid wall stent. Is the closest cell in the one or other?
Yeah, from a technical standpoint, if I understand correctly, this is a road saver, if I understood correctly. But from a technical standpoint, carotid wall stent is not a double layer mesh stent, but the covering properties of a carotid wall stent is absolutely very high. But the real point in this lesion is the fact that, as previously said, this is a very embologenic plaque with a huge soft component. When you place a stent over there, even if you gently post-dilate, many times the interaction between the stent meshes, even with a double layer mesh stent, the stent meshes and the plaque is going to cut really to dissolve the plaque, and you have plaque protrusion. In this case, I disclose immediately my position. When I see this kind of situation, I put immediately a second stent inside, what is named the sandwich technique, and many times I don't want to post-dilate. I want only to have the possibility to entrap this huge plaque protrusion between the two stents and stop.
Dr. Cremonese?
Yes?
I'd like the question about this. It's possible in this complicated case use a type of wall stent, because the closed cells in my routine, I have a good experience of wall stent and precise, both for the standard stents, real world in Brazil. Sometimes I can use two stents the patient because the insurance problems, etc. It's secure to use wall stent, closed cells, and they paralyze the patients without put a second stent. What do you think about?
Yeah, it can be a good choice to place a carotid wall stent. Is the stent probably we used mostly in the past, and is really very safe and effective. Absolutely. Okay.
Okay, but any more comments?
Okay.
We have noted the problem of the plaque protrusion. The second stents, any other ideas?
No, I think in this case, is the plaque protrusion, even with a double layer stent, as Dr. Cremonese said, the most immediately action is to put another stent. In this case, we need to take in account these are very tight lesions, and we need to put or deploy the second stent very carefully, because we can find some shear stress during the advance of this second stent, and sometimes we can make a shortening of the first stent, and we need to do with very careful this deployment.
Okay, Estêvão, what is the final?
So just to comment here, we saw exactly what you have seen is a protrusion here of the plaque, the accordion effect here, and also a kink in here. This is the aspect of a kink. So we know that the artery is fixed to the brain and also on the thoracic part. But on the carotid, as we had a lot of tortuosity, it should accommodate it in some place. So here, the moment is stressing the vessel to be rectified. Here, the stent has rectified the artery. So you just push up all the tortuosity. So I'm not very concerned about this accordion effect. I'm not concerned about this kinking effect, but I'm very concerned about this image here that, as you can see in this zoom, that here is the stent struts, you see, in the tail, and here is the endoluminal limits of this artery. So it's a huge plaque prolapse in this case, you know. So we decided for sure to enter again into proximal protection device into flow blockage, and as Dr. Roberto said, to implant another stent, the same size, the same technique, you know, and after, of course, aspirating all the blood of column of blood here, verifying the results and removing the filter, we achieved this result here in this case. You see that the accordion effect was relieved after removing of the filter. We cannot see that prolapse. We did not posilatate this lesion because of what Dr. Cremona said. We cannot stress the lesion there. And then we did a final cerebral angiography, and now we can see that here the anterior cerebral artery has appeared here, much more easy seen here, and also the posterior and the middle cerebral artery in this case. So the patient had no intolerance for this case, and this is the very final shot with resolution of the plaque prolapse, and the patient was discharged home asymptomatic, I must say, on day 5, and she recorded a video for me, but I was not able to put here in the presentation, but she is very good. And I must say that this patient is the aunt of my partner of work, Dr. Valerie Fuchs. So it's not just a patient, it's a very special patient, and we were very aware about all the things that we were doing with this lady. So I think that we are going achieving our end. So as take-home message for this case, soft carotid plaques always carry a higher risk for distal embolization. Some specific lesions can be even with higher risk, like this I call Ferrero-Rocher plaque, you know. Post-dilatation is the highest risk phase of carotid artery stent for sure, and also manipulation of the aorta. Proximal cerebral protection device has been used for high-risk lesion, and plaque prolapse should be promptly recognized and treated as soon as possible. I thank you very much.
Wonderful, Estêvão.
Wonderful.
Fantastic case.
Beautiful.
Well, Dr. Anibal Damas, are you here?
Yes. Can you hear me, Mauricio?
Yes.
It was an excellent case. Thank you, Estêvão, for sharing the case with us, with several teaching points and several very nice comments from Dr. Cremonesi and Mauricio and all the others.
Dr. Damas, do you think we have time for some questions from the participants? Because I cannot see the questions here, but maybe you can see and choose some for us to answer, to finish.
Yes, there have been so many questions during the webinar that most of them have been answered during the presentations. There is some very interesting question, maybe very relevant from the clinical point of view, as how we manage these patients in the time of COVID pandemic. And maybe Dr. Cremonesi will be able to make some comment about it. And one question says that as the result of this ongoing COVID pandemic, we have seen almost the person, the participant who makes the question, he says he had seen almost all the hospitals in his region operating at a maximum capacity. How has this changed the way we manage carotid artery stenting or carotid artery stenosis treatment, specifically in these patients? And I mean, this have to do with the time to treatment. Would you like to make any comment about that?
Yeah. Very honestly, we decided during the peak of the pandemic to treat only very symptomatic patients. But another good point, consider that we have 3 labs in my institution, and we decided to dedicate a single lab only to COVID patients. So for this reason, we accepted only very symptomatic patients, but also for coronary or for any other peripheral intervention, not standard cases. Any standard case was delayed to be treated after the peak, for the simple reason that in our intensive care unit, the most of the beds were dedicated to patients ventilated. For this reason, really, we reserved all the interventional procedure, but also the surgical procedure, only to really very symptomatic or high-risk patients. This was the only. But I have to say that also the clinical presentation changed completely. We had many arteritis in this kind of patient, COVID patient, and in some patients, just some days ago, I had to treat a COVID patient. I had to treat a lesion, an incredible lesion where the diffusion of the disease was all along the carotid, means the bifurcation, below the bifurcation in terms of plaque, eruption, everything. So means that in my mind, COVID disease is also related to a diffuse arteritis.
Thank you. Thank you. Okay, Mauricio, I think that we are beyond the stipulated time for the webinar. So we should summarize this webinar. Would you like to make some final comment and maybe let me 1 final minute to make some advertisement about some SOLACI activities?
Okay, go ahead.
Okay, if you don't have any other comment, Mauricio, we can share with the participants the final slide. Okay, on behalf of the SOLACI board, I would like first of all to congratulate Mauricio and all the members of this new area of SOLACI, which is SOLACI Peripheral, for setting up this webinar, which has been very successful. As Mauricio mentioned, we had almost 500 participants. I would like to remind all these participants also that we encourage them to send abstracts and challenging cases to the upcoming SOLACI meeting, which will take place on February 28th to March the 2nd. And the deadline for submissions is July the 21st, 31. I would also like to remind the participants that the chapters of nurses and technologists has organized a webinar next Saturday evening. So take a look at the SOLACI webpage. Of course, I would like to thank very much Dr. Alberto Cremonesi for taking his time so late at night after a day of hard work to stay with us. So this is my last comment. And again, have a good night, all of you. Thank you, all the presenters and panelists. I hope to see you soon in the next SOLACI webinar. Thank you and congratulations to SOLACI Peripheral.